And hello, everyone, and welcome to today's session. Just to make sure that can anyone tell me that I'm being audible and clear? Okay, thank you so much. Okay, so we have a few participants, and let's just wait for another 2 to 3 minutes so that we can formally start our class. And thank you everyone for joining in. I hope this session comes out to be useful for you, and I hope that I expect that a lot of you are here, uh, are people who are here to join, who are are preparing for the exam. And you know that there's a wide variety of topics that comes in the exam. And one of the very major component of your GI system is the chronic diarrheas. Whenever you read the GI system, one of the very important parts of that is the chronic diarrheas. And celiac disease is one of the most important causes that come in the chronic diarrheas, especially in the children. So that's why we decided to have this topic discussed today, because all of you who are preparing for the writtens, obviously, you guys are going to appear for the clinicals as well. And this topic, celiac disease, is not just important for the writtens. If you have a good concept of how to diagnose this, how to have an approach of a case with disease, then this is going to help you a lot in your writtens as well as in your clinicals as well, because a lot of part, it can come in almost every station in the clinical exam. So it's 6:01. We'll just wait for another 1 or 2 minutes. Till then, if any one of you wants to ask, okay, first let me introduce myself. I haven't done that. I am Dr. Iqra Ahmed, and currently I am working as senior registrar in the University of Child Health Sciences, which is one of the main children hospital and institute in Lahore, Pakistan. And I have done my FCPS from Pakistan, and I completed my MRCPCH last year. I gave my returns back in the COVID times, and then I got to do my clinicals from the Pakistan station. So yeah, we see a lot of patients of celiac disease. We have been managing this in our daily routine as well. But obviously, for the exam, you have to have a different kind of approach, especially for the writtens. You need to be very specific about what's written in the books, what's written in the guidelines, and we'll go through that in the next 1 hour. If any one of you has any question before the session, I would like to take that, and then we'll be starting. You can message, you can drop in a message, or okay. So I think if there are no questions, so let's just not waste time and let's start into the topic. So as I started earlier, that celiac disease comes under the umbrella of the chronic diarrheas. Chronic diarrheas have different causes at different ages of life, starting from the early life, where you can have the scenarios of cow milk protein allergy, some congenital diarrheas, then moving on to the child who is um, uh, eh, from 6 months onwards, when the diets are included, then you can have the celiac diarrheas, then we have toddler diarrheas. When a child grows up and he's having diarrheas, we have the inflammatory bowel disease, which includes Crohn's disease, ulcerative colitis. So there's a very big range of how you have to come out the chronic diarrheas. So the celiac disease, let me just, okay. So I hope my screen is visible to all of you. So we'll start with the definition. Celiac disease, I want you to focus on every word that is written on the slide. So it's a reversible. Reversible, why would we say that this is reversible? Because this is a disease in which certain damage is done to the lining of the gut. And that is due to the it's a reversible immune-mediated enteropathy of small intestinal mucosa caused by the heightened immunological response to gluten. So let's just break this down. So the first thing written is that it is reversible, which means that the damage which has been done to the gut, to the mucosa, over the period of time due to the chronic exposure or the multiple exposure to the gluten, it can be reversed if we stop giving that specific stimulus to the body. So what happens in the celiac disease is, as most of you might know, immune mediated, it means that the body produces some body produces some antibodies, which we call autoantibodies, to some of its own part. So what happens is that the certain parents when the certain patients, certain children, they are exposed who have some genetic predisposition, who have some other factors in the body, and they're exposed to a certain component, which specifically in this case is the gluten. A certain antibodies are developed in them. And due to that antibodies, those antibodies act majorly on the internal surface of the small intestine, its mucosa, and they cause damage. What happens is that, that the small intestine is the main area of the absorption of the food that we eat. So what happens is then when the mucosa is disturbed, the mucosa gets, it gets eroded, this flattening. There are certain features which are associated with it. So the capability of the small intestinal mucosa to absorb all the nutrients from whatever the food we eat, it gets decreased. And what happens later on is that the patient is not getting obviously that the food is not getting absorbed. So what happened is that the food which is being eaten, it is going out of the body without providing the proper nutrition to the child. The food goes out, which comes out to be the main symptom, which is basically the diarrheas. And then due to the lack of the absorption of all the nutrients from the body, there's a wide variety of the symptoms that we can get in the patients of the celiac disease. And these are extraintestinal symptoms, and we'll be discussing in the next slide as well. So why is this important? Because that the reversibility of this implies to the importance of the treatment that we are going to have, and importance of the symptoms that comes in the patient. And once that stimulus is being removed, gradually, slowly, the healing process of the mucosa goes on. The mucosa, the lining gets healed, and the symptoms, all of those that were present earlier, they can be reversed to quite a major degree, and the patient gets to live a near normal life if we can diagnose it in time, if we can treat it properly, and we can manage such a child in a good way. So it's important to have the definition in the mind. Next important thing that's written here is that there's association with the HLA, DQ2, and DQ8. The importance of this association means that HLA, these haplotypes, they are associated with certain other autoimmune conditions as well. So, when there's this defect present in a specific child and he has one autoimmune condition, you need to screen the child for the other autoimmune conditions as well. That's how it goes. And that is why it's really important to keep this in mind. And this is important for the screening and the testing in the later labs, and we're going to discuss that as well. It is associated with anemia. One of the very, very major features of the celiac disease is that it is associated with anemia, as the iron is absorbed through the ileal mucosa. So the usual line that you get to read in the text is that it's the anemia, which is refractory to iron supplementation. Because you see that in general population, if we have iron deficiency anemia and you give the iron, so obviously that get better with time because it's being absorbed from the body. But what's happening here is that iron is unable to absorb from the gut, and no matter what, no matter how much iron you keep giving to this child, they have the iron refractory anemias. And the usual age that there's a wide variety and there's a wide spectrum of how the disease can present and when the disease can present. But generally, it is after the 6 months. Why? Because you know that this is a sensitivity to the gluten. And you know that the gluten is usually present in the wheat, in the barley, in contamination with the oats as well. So the grains that are usually present. So till the 6 months of age, most of the children are only either breastfed or they are given the cow milk or they're given the bottle milk, and they're not really introduced to the new foods. So at the age of 6 to 12 months, when they are introduced to the new foods, specifically those who are containing the gluten, and the gluten contains certain components which then affects the child, and then this system of autoimmunity grows up. So this is roughly the usual age, the most common age, but we'll see that it can also be present in the older children as well, and with the different symptoms. So okay, so I think there's some difficulty in changing the slide. Let me just see. Oh, okay. Sorry for the inconvenience. I'm just getting to the next slide. Here it's- can anyone tell me that which slide can you see right now? Okay, now that okay, okay, I have changed it. Probably there's something wrong with the full screen. Can you see the clinical presentation slide right now? Okay, I think okay. I think there's some issue with the full screen, so we'll just go like this. So you can see in the clinical presentation. Okay, so we'll divide the clinical presentation into two parts. The first one is the intestinal symptoms. So, chronic or intermittent diarrhea, which means that the child has recurrent episodes of diarrheas. It can either be a chronic diarrhea, which means that the child constantly have diarrhea. He can have a number of loose stools. Those stools can be large in amount. They can be foul smelling. They can have some mucosa in that, and it can be intermittent, that it slightly gets better because, as I'm telling you, that the issue is how much the patient is exposed to the gluten. So it can be intermittent as well, that there's an episode of diarrhea. There are certain episodes like child might have the diarrhea for 5, 7 days, 10 days, 15 days, and then he might get better because, whenever the child has diarrhea, the parents usually take them to the doctors. They might give them some antibiotics or something like that. Child might be starting eating less, and that the parents start giving less amount of food to the children. So there can be chronic diarrhea or it can be an intermittent diarrhea. Next thing is constipation. That's a very different thing about celiac disease, is that it presents with a wide array of the symptoms. So even the constipation can be one of the causative factors because this is affecting the gut, overall gut motility, the gut functioning. So there are scenarios in the exams that have come when the child was presented. Next, we have abdominal distension and abdominal pain. And we have scenarios in the exams in which the child was just presented with the abdominal pain and the episodes of constipation. And in the first presentation of these two symptoms, these two complaints, you wouldn't be thinking of celiac disease. So it's really important to keep that in mind, that don't just keep the diagnosis out of the picture if you get some other kind of symptomatology as well. Always keep in mind that whenever is a child who is coming with any of the intestinal symptoms, any of the gastrointestinal symptoms, even the recurrent nausea and vomiting, we usually don't see that a lot, and usually it can be associated with the cow milk protein allergy as well. It can be associated with the other some other diseases as well. But celiac disease is kind of notorious to have any of these symptoms, and that can be present. But then, having said that, the most common symptom that you will get is chronic or intermittent diarrhea. Okay, so next up we have the extraintestinal symptoms. See, you can see that there is a big list of symptoms that can present uh, as a part, as a complaint, major complaint of the celiac disease. First one being the weight loss and failure to thrive. In our own setup, in the scenarios as well, we see a lot of children who are simply not gaining weight, and they have a failure to thrive complaint. The parent says that they're not thriving well, they're not gaining weight. When you weigh them, they are below the centiles, 10th centiles, they decrease in weight, height, overall energy levels, and anything of that sort that can present. Delayed puberty and amenorrhea, it is not, it should be a bit down of the list, but it can be present because it might sound strange, but a lot of adult people are diagnosed with the celiac disease at very later age as well. Okay, so one of the things that I would like to keep here in the first position, and I'll just change the sequence here, is that chronic iron deficiency anemia. That's what I was telling you, that iron refractory anemia, no matter what you do to these patients, how much deworming are you doing, how much iron are you giving, it's not getting absorbed. So chronic anemia and iron resistant anemia, it's one of the major complaints. Then we have the weight loss, failure to thrive. The next up, we have delayed puberty, amenorrhea, irritability or chronic fatigue. Yes, we have the kids who are not thriving well and they're just irritable all the time. You see, because when the child is not getting enough food, enough vitamins, these things happen. Neuropathy, this is one of the very important things as well. Neuropathy can be, you see that our peripheral nervous system that's dependent on the absorption of the vitamin B12, that's also dependent of the vitamin E as well. So when there's a deficiency of these vitamins in the body, child can have neuropathy. These children also do present with the ataxias. They have tingling sensations, arthritis and arthralgia. This might not be a very common complaint, but it is associated with it. Decreased bone mineralization is again one of the topmost components of the topmost symptoms that can present, because you see that there's decrease. I'll just transfer it to here as well so we can have a order of a proper order of how it goes. So chronic anemia, decreased bone mineralization, the child is not getting the enough vitamin D, the child is not getting the enough calcium that leads to this decreased mineralization, osteopenia, osteoporosis, and the repetitive fractures as well. Recurrent stomatitis. You see that we have certain children who are getting repeated mouth ulcers. Once or in a while, it's okay. The child can get the mouth ulcers in any kind of infections, in any kind of um, stress conditions as well. But recurrent and persistent stomatitis, aphthous ulcers, these are a common complaint as well. Dermatitis herpetiformis. This is a typical rash. Has anyone seen dermatitis herpetiformis, or have you seen any picture of it? Okay, we might not be able to communicate properly, but dermatitis herpetiformis is one of the main pathognomic signs that are present in the cases of the celiac disease. Uh, this is basically a rash that can appear on any part of the body. It can present. Okay, so one of the patients said that only photos. Okay, yeah, because that's good that you should have photos as well, because you know that one of the important things that comes in your AKP exam is the photo as well. And let me see if I can just show you a picture of dermatitis herpetiformis. Okay, so I was telling you that dermatitis herpetiformis is usually um, a rash. It can present on the trunk, it can present on the limbs, it can be anything. Okay, let me just share it. Okay, so you see, these are the different examples of how you can have the dermatitis herpetiformis. It can be present on the back. It can be present. Usually, it is present on the arms. I have the most of the cases that we have seen is arms around the elbow area. It usually presents like this vesicles and which crust they have certain erosion and they're distributed over the extensor areas more on the extensor surface of the back of the body, on the knees, around the knees, elbows, buttocks. And one of the important thing is that it is a really itchy kind of a rash. It causes itching and it's very pathognomic. So you can have a scenario in your exam as well, where we are having uh, the case of a case of a child who's having this issues and who's having diarrheas and everything, and he's having the specific rash. So if you have certain kind of this kind of rash, then that can typically point towards the rheumatitis herpetiformis. And they usually ooze out when you scratch them, and at times they leave the crusted erosions as well. And one of the important thing is that they usually are present bilaterally and symmetrically, and they are often grouped together as well. There's not a single lesion. There are groups in the picture, as you can see, that there's the group of lesions that are present. So it's important to have that picture in your mind as well. Then we can have dental enamel defects as well, because obviously proper due to improper nutrition and everything, and even the abnormal biochemistry, because you see the GI system is involved, and any of the things can be present. Okay, so this is up to till now that we have associations. Okay, initially, I told you that since this is an autoimmune disease and it is associated with HLA, DQ2, and DQ8. So autoimmune disease, always keep one thing in mind, but that when there is something defect in the immunity of the body, and there's certain autoantibodies are produced in the body, they do not just affect the one system at once. Why? Because you see that our body has certain receptors, and those receptors can be of a combined origin at a different point, at a different place in a body as well. So whenever certain antibodies are produced, they don't just act on one single system, they are acting on the multiple systems as well. So that's what happened, is that this association of celiac disease is present with the type 1 diabetes, because that's a condition as well, autoimmune thyroiditis. There's a selective IgA deficiency is associated with celiac disease as well. There's a slight association with the GIA as well, Down, Turner, and also I would like to add in this that even adrenal patients with the Edison's disease, they are associated with the celiac as well. Other than that, we also have an association with the pernicious anemia, because that's autoimmune condition as well. So this is important to keep in mind, because how are we going to screen? Who are we going to screen? So any of these patients, like the first degree relatives of the patient with celiac disease, the patients who are having the type 1 diabetes mellitus, autoimmune thyroiditis, ID deficiency, GIA, Down, Turner, all of these patients should be screened from time to time for the celiac disease. And that's how it will, because you might have been preparing for the diabetes as well. And you must know that there's a timeline of that, when do we have to screen the patient of diabetes for celiac disease, how do we have to do that and everything. Even in this very common association with the Down syndrome as well, these come in the scenarios as well. That's why this is important too, because you might have a scenario where there's a case of Down syndrome and the child might not be thriving well, and he's having certain issues right now, and you might be asked that what kind of screening you would like to do in this patient. So you can have celiac disease case in the AKP in that kind of scenario as well. So these are the name of the certain invest. Okay, so first thing first, firstly, so we were discussing about the signs and symptoms and the association. So our major bulk of the MCQs that can regarding to the AKPs. So we are not just discussing the disease, we are also going to discuss how that can come in your AKP exams specifically. So you can have the questions where you are having the signs and symptoms, and you are going to have uh, a diagnostic problem, and you're going to diagnose that, or you can have these associations. The very important thing, and we're going to spend some time on understanding this, and I want all of you to be very attentive right now. These are the name of the tests that we can do for this screening and for the diagnosis. And later on, I'm going to tell you that how do we do that. So the first test, that we have anti-tissue transglutaminase, IgA. The most important and the most common test, the first test might be that we do is the anti-tissue transglutaminase. So you see, there it means that these are the antibodies, and these are IgA antibodies, which are being present in the body, and they are detected whenever you have to screen for the celiac disease. The next one is the EMA, anti-endomysial antibodies. I'll tell you that when do we do that. Other than that, one of the other diagnostic approaches that we can do is the duodenal biopsy. This is not done in every scenario, but if it's done, the features that we can have in this case is the intraepithelial lymphocytes. There's because you see this, it's an inflammatory process, and there's the infiltration of the lymphocytes in the inner side of the epithelium. This blunting of villi, which we usually call as atrophy of the villi and atrophic villus. And what happens is that, that villi, they are the finger-like projections present on the internal surface of the small intestine. And this surface, this the villi structure, and this are very important for the proper absorption of the food from the body. So what happens due to the blunting of this villi is that the internal surface of the small intestine, it just gets flat. Does not the absorption surface area gets very decreased. There's no area for the food to be absorbed. So there's a total flattening of the villi, and that leads to the decreased absorption as well. And then we can also have the crypt hyperplasias. So, can anyone of you tell me that where else can we find the blunting of villi? In which other disease can we have the atrophic? Because that needs to be kept in mind as well as a differential.
Tropical screw.
Sorry, can you write it down in the comment section? Okay, 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 we won't waste our time on this. I'll just tell you that the most common cause we've discussed that it's in uh, the atrophic villi that is present in the celiac disease. The other causes, it can be in the recurrent gastroenteritis, eosinophilic gastroenteritis, giardiasis. It can be present in certain cases of the cow milk protein allergy as well, tropical sprue. So any causes that are present of the recurrent diarrheas, malabsorption syndromes. Yeah, celiac disease is basically, yes, a malabsorption syndrome. And malabsorption basically occurs as a cause of this atrophic villi. The other causes, as I have told you, are the chronic giardiasis, eosinophilic gastroenteritis, and the certain cases of caramel protein allergies, and the tropical sprue. These are the cases where you can have the villus atrophy as well. Okay, so these are roughly the tests that are usually done. Other than that, we can also do the HLA screening, HLA haplotyping. That is usually done in the cases where there's association with the other things as well, or we are screening the patients which are related to the patients of the celiac disease. It's not done in every other case. The normal levels of the tissue transglutaminase is 0 to 4 units per ml. And next, the most important slide that I want all of you to focus right now, we are going to do it very step by step, and I want you to really, really focus on this, is that how do we approach and diagnose a case of celiac disease? This is according to the recent guidelines, which are of the ASPAGAN. They are 2020 guidelines. We will be sharing that guidelines in the group as well. I will be sharing in the chat box as well. These are that are really, really important. There are certain changes that have been done. Previously, it was said that most of the people or every child should go through the biopsy to make a final diagnosis of the celiac disease. But the recent guidelines say that you need to have a less intrusive, and you need to have approach which is not very you don't have to do the duodenal biopsy in every child to make a diagnosis, and you can have an alternative pathway as well. So if you have a child with the clinical symptoms indicated of celiac disease, or there's a elevated risk of celiac disease, you will do two things in that patient. You will do anti-tissue transglutaminase IgA levels and the total IgA in the serum as well. Why are we doing it? Because as we saw in the previous slide, that IgA deficiency is associated with the anti-tissue with the celiac disease as well. So what can happen is that child might not have very high levels of anti-tissue transglutaminase IgA because he's having a total IgA deficiency. So if he's having a total IgA deficiency in the body, his levels might not be what we expect. So there can be a discrepancy in that cases. So first step is always do both anti-tissue transglutaminase IgA plus total IgA. This is a very important MCQ as well. So whenever you get that option, select one that is having both of them. So we'll come to this first. Just look at the left side of the picture where you see that the anti-tissue transglutaminase, they come out to be positive. Okay, so they have positive, which means that they are increased. Now we are going to see that how much are they increased? What's the level of increase in them? To the total left, you can see that if the tissue transglutaminase are more than 10 times of the normal upper normal limit. So what level did we see? The upper normal limit was 0 to 4 was the normal limit. So 4 is the upper normal. So 10 times the 4, if the levels are above 40, you you are fine. That this means that the child is having celiac disease most likely. Thus, you do not have to do biopsy in every case in that case. So you see that the tissue transglutaminase levels are 10 times the normal values. The next step in the yellow box you can see is that you test EMA IgA. What we did study that it is anti-endomysial antibodies, IgA. If that turns out to be positive as well, your celiac diagnosis is confirmed. You do not have to go for the biopsy. So what we did was anti-tissue transglutaminase IgA, that came out positive. The second thing was the EMA, that came, the levels were more than 10 times. You did the EMA, that was positive. You have diagnosed that child with the celiac disease. You are going to refer that child to the enterologist, and he is going to do all the follow-up of the celiac disease in that child. The second scenario is that you got the levels of more than 10 times, and then you tested for the EMA, and that came out to be negative. In that case, you have to go for the biopsy, right? So you can see from the arrows in that case. So one is positive, more than 10 times normal, the EMA is negative, we are going to go for the biopsy. The other scenario is that the anti-tissue transglutaminase, they were positive, but they were less than the 10 times of upper, upper limit, which means that they were below 40, they were between 10 to 40. So what are we going to do then? In that case, we're going to go directly for the biopsy so we can have a proper diagnosis, right? So I hope that this stem, the left side of the part is clear. And what do we have to do when the IgA came out to be positive? The other scenario is that the anti-tissue transglutaminase is negative. So in that case, two things can happen. Here we are going to get help from the total IgA levels. In this case, if the total IgA is low as well, it means that there might be a false positive result because we're not having enough IgA. The child already has the IgA deficiency. That's why the levels might not be increased. In that case, then can test the IgG, anti-tissue transglutaminase, EMA, or DGP. DGP is also another antibody that can be associated with the celiac disease. And this stands for, yeah. So DGP basically is a deamidated gliadin peptide. So you don't need to remember this name a lot. This DGP is fine. So you are going to do this in cases where the result is inconclusive. So you can have the IgG, TTG, DGP, or EMA. If any of these tests, IgG is positive and any of the other tests are positive, then you can go for the biopsy. There you are going to go for the biopsy. Why? Because there's certain chance the child might has the celiac disease. So we are doing the biopsy in three cases. When the levels were more than 10 times normal, but EMA was negative. When the level was less than 10 times the normal, and the levels were negative, but then there was total IgG deficiency as well, and IgG came out to be positive. So they are the three indications in which we are going to go for the biopsy. And the last one, to the total right, we see that the IgA levels are normal, the IgG test came out to be negative, and it means that there was and there's no other okay, what can happen in that case as well, that there's no risk for false negative serology, gluten intake, that we have to see that the child is taking the gluten or not, child might be on some other drugs. If we have ruled out all the other things, then we have ruled out the celiac disease in that case. Why is the gluten intake written in this? Gluten intake, whenever you are testing for the celiac disease, it's very important to have a concept that at that time, whenever we are testing, the child should be having enough levels and child is on the gluten. So what happens is that the children might come and someone might have told them earlier that the child might have the wheat allergy and they have stopped taking the gluten. So what happens is that if that stimulus is not present in the body and the parents might be giving him some food which is not the high in gluten, and then the antibody level might not be properly, or the biopsy changes might not be proper in those cases. So whenever we are going to test the child, either it is the IgA autoantibody level or the biopsy, the child should be on a proper gluten diet so that we can have the proper levels and we can make a proper diagnosis. So this is a really, really important slide. And I want anyone, if anyone has any kind of question regarding this, I wanted to clear it right now so that we can proceed further. Okay, does anyone have any question? Is it clear to all of you? Okay, that's good if it's clear. But I will highly recommend that you guys ask question and share any of the comments that you have, because that is going to make me clear which medication can cause false negative. Immunosuppression drugs, if the child is having any other condition, like we discussed that it is associated with the other condition, because you see, whenever the child is on the immunosuppressive medication, obviously the immunosuppressive means that the body cannot produce the enough antibodies and its immune system is depressed. In that cases, there can be a decreased uh, production of this anti-tissue transglutaminase, and that's usually associated, if it is associated, if the celiac disease is associated with any of the other conditions. Okay, so till now we have discussed signs, symptoms, how to approach, and we have discussed how the questions can come. The next one obviously comes out to be the treatment. So this is one of those diseases. Okay, we have another comment. How much amount of the gluten is required for the positive serology? Okay, so there's not a specific recommended amount. It's just that the regular, whatever the regular food they are eating, there is a cut off value present, which is 20 parts per million. That this is the maximum that a child can take with the celiac disease, and it will not cost 20 parts per million, which is a very small amount. Yeah. So if the child is taking more than that, then the body is going to produce a response. Okay. But that's not really identified as typical thing. Why for the biopsy if the anti-tissue transglutaminase is negative? Okay. So we see in this scenario, if I may go to the previous slide again, if you see, we saw in this, when the anti-tissue transglutaminase is negative, we are considering the total IgA levels as well. So in the blue box, you see that the total IgA levels are low. So imagine this thing, that a child has a disease, has total IgA deficiency. He's unable to produce IgA in his bodies. So that is why anti-tissue transglutaminase will not be produced in the enough amount that can be detected, because the whole IgA levels are low. In that cases, we do certain other tests. We do the IgG levels of the TTG, DGP, and EMA. Any If IgG comes out positive in this case, if any of these tests came out positive, then we go for the biopsy, because the initial negative test might not be due to the negative disease. It might be due to the total low IgA levels. And obviously, this is something we have to make a proper diagnosis. Okay, I'm going to tell you a bit about the biopsy as well, that usually the biopsy is done from the duodenum, and usually 4 samples are taken. And it is said that 2 or more samples should be from the duodenal bulb. All 4 samples are screened, and there's a classification that is called the Marsh classification. I have not added it here because it's not that's a very high thing to learn. But if you have any of the interest, and the guidelines that I will be sharing, they include that small information, the Marsh classification. There are 4 classifications: 0, 1, 2, 3. And according to that Marsh classification, you decide that whether the child is having the celiac disease or not. So I will share the guidelines and you can read that from there as well. For long, a child should be on gluten diet before taken biopsy. For how long it does not mean it should be, the child should not be gluten free. I mean, what happens in the local scenarios is that we suspect gluten diet and we ask the parents to just stop giving the diet. And the parents stop giving the wheat and the regular diet. And when the biopsy is taken, it comes out to be inconclusive. So it should be a normal diet till um, we do the proper biopsy. In previous times, there was a thing that we used to call the gluten challenge as well. The child was kept gluten free for some time, and it was seen that whether there is any difference in the symptoms or not. And then the child was reintroduced with the glutens, and then it was seen that whether the symptoms come back to out to be positive on that. But then that's a very kind of a dangerous thing to do, because now we have very good investigations and everything and biopsy findings, and we do not need to put the child under certain kind of stress to make a final diagnosis. So gluten challenge is not done now, but it might be of some interest to you if you keep that in mind. Okay, so yeah, thank you for all the questions. Do give a read to the new guidelines that I will be sharing. Let me just, I'll share them at the end of this meeting, and in that you can have a summary of all of these things that we have done, and you can just read through them today, and this is going to get fixed in your mind, and you're going to get a very nice concept of other things as well. Okay. So the good thing about celiac disease is that it does not, you do not need to remember 1,000 medications or a very long approach of how to treat, what to treat and everything. The simplest treatment of this drug is remove the gluten from the diet. That is the main thing. Why? Because all the thing that is happening wrong in this child is because the gluten is in the body. It is giving a continuous stimulus, a continuous trigger, continuous autoantibodies are being formed, and these are affecting the child in a lot of ways. Once you remove the gluten, those antibodies stopped being produced in the body. And the ones that are already present in the body, they are going to be diluted. They are going to get away from the body. The gut starts healing. It comes starting coming back to its normal formation. The villi starts forming again. There's a proper absorption area, and then the child can come to near normal, almost normal values. Now, along with that, obviously, the gluten, when we are going to remove the gluten from the diet, it is definitely going to reverse the damage slowly. But there has already been a great amount of nutritional deprivation that has been present in that child. So obviously, you have to compensate for that for certain period of time. You have to give calcium and vitamin D supplementation. Obviously, here the supplementation is not just limited to that. You have to add the iron supplementations, maybe other multivitamin supplementations which are needed. Then you have to keep the patient on repeated follow-up. You have to have an annual review of height and weight. You have to have see the patient which has been you have to screen the patient for the other autoimmune disease with the time as well. You have to have a proper bone density assessment, feed that, counsel them if needed, screen the other family members as well, and just keep the patient on proper follow-up. Now, it's important for you to know that which foods obviously you are going to tell to the child, because you see that in the different parts of the world, majorly in the Asia and every here, the main focus and the main diet is supplementation is through the wheat, the roti and everything. And that is going to play a major, so you have to have a full lifestyle change in the of the child and of the family as well, and you're going to give them proper diet charts. They need to know that what can they eat. There are proper diet charts available. Now, this gluten sensitivity is a common thing, and a lot of you might have seen that they're very number of things. We have got gluten-free flours, we have got gluten-free bakeries. So you have to tell the child that the parents, that what they can give and how they can keep the patient healthy with that. Okay, so one of the questions that we got in the comments, let me just read that. Okay. So can you please give some examples containing gluten besides wheat? Okay, so it's present in the wheat, barley, rye, and the oats. Originally, if oats are very clean and everything, they are very separately made. They do not contain the gluten, but due to the cross contamination, it is usually said that they should avoid the oats as well. So, what options are left then? You have to, they can eat the corn flour, like the maize, corn. They can have the rice in any form. They can have all the fruits. They can have all the proteins, uh, meat. They can have all the vegetables, but they need to avoid the gluten. You see that the white flour, or the what we call maida in as well, the white flour and the proper brown flour, all of these contain the gluten, and which means that you see that a lot of the bakery products and the breads and most things that we eat usually have that. So you have to counsel the parents that they need to avoid the cross contamination as well. If they need to make the rice flour or any other flour, they need to make it in a separate one. They need to cook the food in the separate pans which do not have the contamination from the gluten or gluten containing products. So that's very important. The major one is the dietary. So whenever you have the any of the MCQs, and so major component is the gluten-free diet along with the supplementation and then the follow-up. These are the main points. Okay, so we can also have certain, you see that around regarding, okay, we go to the exams. Before that, we'll discuss that what complications can we have in these children. As I told you that it can affect any of the systems of the body, and we from the CNS to the musculoskeletal system to the GI, and almost each of the system to the oral, almost every system was being involved in this as well. So it can cause certain complications. One of the few things that are associated with the celiac disease are a slight increase maybe of the development of lymphoma in the cases of the celiac disease, which might be present in that. So we need to keep that in mind, that they have a slightly higher incidence. If not treated properly, they can have a slightly more incidence of lymphomas as well. So this was mostly about how we diagnose, how we see, how we think about celiac. Exam scenarios. How can you have that specifically in the AKP exam? So you can have the diagnostic scenarios based on the signs and symptoms. I have gone through the recalls, and there have been cases which, okay, I'm going to share them in the next slide as well, and then we can have a discussion on them. We can have investigations, what to do, when to do. You can might be given certain values of the tissue transglutaminase, and then ask about what to do next, when to do the biopsy, the findings of the biopsy as well. You're going to have the questions related to the management of the disease, how and what are you going to do? Okay, and association. One of the questions that arise, I saw somewhere, was when a child of the type 1 diabetes mellitus, he was on a good control of the diabetes, the HbA1c was good, and the sugar levels were good, and everything was going fine. But the child was not, the child was um, having decreased weight. The child was losing weight, and she was not interested. She was feeling a generalized weakness. And the cause came out to be celiac in that case as well. So you see that in the adults who are having these autoimmune conditions, you might not get a proper case of diarrhea or something like that. And it can be very subtle signs and symptoms. So I'm going to share a few. This is from the recalls that I got, and if you can see that this was one of the questions of the extended matching questions that I think that have been dismissed from the AKP. but obviously it's an important topic. And you see that a 12 years old known patient of type 1 diabetes mellitus presented with a poor growth, anemia, low albumin, normal TLC and platelet. Okay, 11.5 is not value, but obviously recalls are not very fine. But you see that what I was telling you, that type 1 diabetes mellitus case, he was now having bad growth, anemia, and the answer in this was the celiac disease. Yeah, other ones are okay, we'll just skip that for now and go to this one. This I have taken from the clinical cases of AKP. And you know that clinical cases, it's one of the most important books that you read for the exam. So I'll just read it out, that a 3-year-old boy presents to your clinic with a 1-year history of abdominal pain with periods of constipation. So you see, there's a 3-year-old boy, he's having abdominal pain and he's having constipation. And it's alternating with the periods of loose stools. He's reported to pass a hard stool once weekly with difficulty, but also has periods of loose stools for a few days every month with some soiling. He's generally said to be irritable and lethargic. He's a fussy eater, has a poor appetite. So you see, all of these are the markers that you need to point out. He does not like vegetables or fruit. He also had severe prolonged episodes of mouth ulcers. One of the important things that I mentioned as well, he is fractious on examination but has abdominal distension. So one of the very important signs is, probably I didn't give much attention to that previously, was abdominal distension. You might get even a picture of, even you see, that's an important picture of the clinical exam video station as well. When a child, a malnourished child who is having very thin arms or legs, and he looks very lethargic, and he's having gross abdominal distension. So that's a very distinctive picture. I'll show it to you after this as well. So you kind of have a picture in AKP as well, where the child is having all of this, and even the picture is given where he's having abdominal distension with no palpable masses. His weight and height are on the 10th centile. His parent health record shows that he followed the 25th centile for the first 2 years, and there were no measurements for the last year. In the blood results, you can see that the hemoglobin is 109. WBC counts are normal. MCV is decreased. The normal value, you know, that it's 75 above. MCH is on the lower side as well, and the MCHC is less as well, and platelets are on a relatively higher side, because you know, whenever there is an iron deficiency anemia, you get to have a compensatory thrombocytosis with that. So, okay, yeah. So the options here are Beckett's disease, celiac disease, Crohn's disease, diet-related constipation with overflow, Hirschsprung. So what do you think is wrong? Obviously, I know we know the answer here, that celiac is very as the one in this one. So the next one is, which of the following investigation would be most helpful at this point? So I want you guys to take a minute, have a look on this investigation, and tell me that what 3 things you are going to do. I'll just anti-tissue transglutaminase antibodies, dietetic assessment, fecal calprotectin, HLA haplotype, a ileocolonoscopy with the biopsy, IgA levels, IgG and IgM levels, rectal biopsy, slit lamp, stool culture, and fecal occult blood, and upper GI. So we have an answer in our chat in which it's written B, which is probably for the first one, yeah, celiac disease. I want anyone to answer this, that what are we going to see in this one? A, F, and K. Okay, so A is anti-tissue transglutaminase, F is IgA, and K is upper GI endoscopy or the duodenal biopsy. Okay, we have another answer. AFK. Okay, both of them. So okay, so let's just see the key. So yeah, okay. Oh, okay, I think I did not put the key in this one, but yeah, I'll just share it for you, and just give me a second. Yeah, so obviously you guys are right that we are going to do the anti-tissue transglutaminase. That's very important in this case. The other thing that's important in this one, and with that, it's A, B, and F. B, dietetic assessment. Because you can read it, it's case 46 of your AKP. Yeah. Most of you have written AFK, right? So I want you to go after this and have a read on the case 46 of the MRCPCH-AKP clinical cases. And the answer for this is anti-tissue classroom maintenance. B, dietetic assessment, because I told you that dietary assessment is necessary whenever you're having a case of celiac disease, and F, IgA levels as well. K, you see that we're not going to do duodenal biopsy in every child. It's not the first investigation that we are going to do. We are going to decide about the biopsy after getting the anti-tissue transglutaminase levels, right? Because you see, even we can do HLA haplotype in the cases as well, but we are not doing that right now. Another option could have been, yeah, IgA levels. You see, I told you that whenever the child has two things, total IgA levels, anti-tissue, and third thing, that is this one is the genetic assessment. Okay, so the next one is a 10-year-old girl presented because of poor growth and 4 months of ill-defined abdominal pain. On examination, her height was 128, 10th centile, weight was 22 kg, under 3rd centile. She had several mouth ulcers, appeared pale, but examination was otherwise normal. In the labs, we have hemoglobin of 9.6, MCH is 26, MCV is 76. WBC 6.6, platelets are 500, CRP is raised, and ferritin is 15. So, what can be the cause in this one? Yeah. Okay, so yeah, I put it in this one because this one is a case of Crohn's disease. Why? You see, because a little bit of information that has been given in this is about the age of the patient. Because you see, at the 10 year of age, the child would not be presenting with this. So the age is important as well. I did mention that a 10-year-old child patient can have celiac disease, but the signs and symptoms would have been a bit of different at that point of time. So obviously this was in one of the papers. I got this one from one of the papers which have been given on the MRCPCH website, and the answer was of this was for Crohn's disease. So age of this is important as well. So with this we have come to, okay, I'll just show you one of the pictures of celiac disease. Let me just, okay, can you see the picture? I'm not sure if you are able to. Yeah, CRP is also red. That's right. Yeah, that's what we mentioned, that there's a difference. Can you see the picture of a child in, right? I'm not sure if, okay, I'll just share this. Just give me a second. Okay, you can probably see this now. You see that you can see the malnourished child, and there's abdominal distension. You can see the signs of rickets. You can see the loss of buttock fat, and you can see the abdominal distension as well. Similar kind of picture comes, this kind of picture. Sorry, this is not one. Yeah, but usually this one with the abdominal distension. This is a very common, this kind of pictures are common. So you can have these in this as well. So with this, we are almost have come to the ending of our presentation and today's lecture. And I would like to give you time to ask any questions that you guys have. Yeah. Any kind of questions regarding this lecture, regarding your exam, regarding the topic, anything that you guys want to have. Or maybe you can guys can have a comment dropped in our comment section. I'm going to share the guidelines here as well. Okay, maybe you can give feedback on the lecture if you not have, if you got certain, you know. I'm just sending you the guidelines.
So you can have a look at them. Yes, someone opened their screen. Do you want to say something? Okay. So, thank you so much. I have posted the guidelines. You can get download these guidelines. Just go through them, and these are almost the topic that we have discussed and how are we going to manage. There are few additional points in the guidelines as well. You can go through them as well if you want. But even if you remember the only chart that we have discussed here, that the steps of evaluation, how we are going to do that, that would be more than enough for your exam as well. So, yeah, so what message I want to give at you at the end of is that if you, I'm sure that most of you are from different areas of life right now. Some of you might have done some training in pediatrics as well. Those who have done the pediatric training, it's easier for them to get to the topics. For those who have not, it's a bit difficult for them. So keep on reading. Always read the latest guidelines as well. We have just covered one portion of the diarrheas, but I would like you to go through the other detail, like the IBD, the toddler's diarrhea, the congenital diarrheas, and maybe the lymphangiectasias, and the congenital things as well. So go through them as well so that you can have a good appreciation about that. Yes, we will be putting this webinar lecture on the YouTube, and you guys can share it with your friends, or you can refer them to as well. And so we just have last 1 minute. Any questions if anyone has uh, regarding the exam, AKP, or this topic? Yeah, thank you so much everyone for joining in. I know it's difficult to listen to someone for this long, but I hope that it was helpful for you. It cleared most of your concepts and it give you a basic idea of how to approach to this topic for your exam. And just have a good, very, very good concept of this topic, because obviously after AKP, you are going to go to the clinical exam as well. And all of this knowledge and concept is going to help you in that case as well. Yeah, about the other causes of chronic diarrhea, that's maybe we can have a free webinar someday about that as well. Or you can always contact us for our course, and have a proper detailed lectures of all the important topics in our courses, and you can contact us for the further details. So with this, it's 7 p.m. here, and 1 hour has gone. And thank you so much, everyone. I really appreciate this. Gives us a lot of hope and a lot of confidence when you guys join in for such sessions and give such a nice feedback. And hope to see you guys in the next webinar as well. And have a very good weekend. And okay, bye bye. Thank you so much, everyone.